very quickly. All right, so respiratory system, chapter 23. Going along, again, the main function for the respiratory system is for the exchange of gas to take place. Now, aside from that, aside from gas exchange to take place, our blood physiology ends up being maintained by or regulated by the respiratory system as well. One of the reasons that we're able to smell are because of the receptors that we find in parts of the respiratory system, or some of the pathways for the respiratory system. And as you've learned in previous chapters, when we breathe air in, it also ends up filtering that inhaled air as well. And primarily, we spoke about throat, not throat, nose, but also moving down from the nose, the throat, through our mouth. There's also receptors there that help filter that air that's inhaled. The reason we're able to speak, talk, make sounds is because it also, larynx specifically, produces sound. In addition to that, it also removes excess body heat from our system, and also a little bit of certain amount of water as well. The field of study specifically for the lungs is called pulmonology, okay? And the specialist or the doctor that specializes in treating disorders of the lungs is called a pulmonologist. So you have pulmonology, pulmonologist. Moving along to the next slide, what do we have are the three different, or the two different sections that the respiratory system gets divided into. There's the upper respiratory system and the lower respiratory system. For the upper respiratory system, primarily we're looking at nose, nasal cavity, and the throat. Okay, nose, nasal cavity, and the throat. So again, when you hear things like upper respiratory tract infection, this is where the infection is related to. Maybe it's in the throat, or maybe it's in the nose, or somewhere in the nasal cavity. Now, as for the lower respiratory system, when you hear people saying they have a lower respiratory tract infection, again, pneumonia, for example, okay, that tends to be lower. That is lower respiratory system. Again, COVID is also lower respiratory, even though it affects it moves through, but primarily it affects the lungs over here. This is the target for coronavirus, at least. So what are the components for the lower respiratory system? They are the larynx, they are the trachea, the bronchi, and then, as I said, the lungs. Now, functionally, the respiratory system is made up of two parts. It gets divided into two parts: the conducting zone and the respiratory zone. This is where the gas exchange is taking place between blood vessels in the cell, and this is where the air is just moving through from the outside environment all the way down to the blood capillaries. Okay, for the conducting zone. So when you now conducting zone. For when you look over here, what do we see over here now? Over here we see the pharynx. That's over here. That's your throat. So again, this is your mouth. This is your tongue. So right up until where the larynx starts. Where the larynx starts, the pharynx ends. Right? That's all. That part is the pharynx. Nose is also part of that. This is all upper respiratory system. Now, once you start over here at the larynx, going down through the trachea into the lungs, this is all lower respiratory system. This here are lungs, and this is the lungs of a smoker. So do not smoke. Very bad for you. Again, when you look at the lungs over here, 1, 2, 3 lobes. This is a little bit larger. And over here, you can see 1 and 2 lobes. The reason you have 2 lobes on this side, and this is slightly smaller than the right side, is it's there to help accommodate the heart. Here's that notch over here within that lung for the heart. Let's see what is next. What is next is we start talking about nose. All right, so we have, all right, so nose gets divided into external and internal parts. Now, we have an unpaired septal cartilage, okay, that forms the anterior part of the nasal septum. And again, this is a partition that divides the external and the internal nose into right and left chambers, okay? The septal nasal cartilage is connected to the perpendicular plate of the ethmoid and vomer that ends up forming the remainder of that nasal septum. It's also connected to the nasal bones and the lateral nasal cartilages, right? So As far as the lateral nasal cartilages go, again, cartilages with an S, that means it's plural. Therefore, we have a pair of lateral nasal cartilages that forms the sides of the mid portion of the external nose. And they're connected to the nasal bone, the maxilla, the septal nasal cartilage, and the major alar cartilage. Okay. We have a pair of major alar cartilages that form the sides of the inferior portion of the external nose. Okay, and this is what people tend to get corrected a lot of times when they have cosmetic nose surgery. So the major alar cartilages, they're connected to the lateral nasal cartilages and the septal nasal cartilage. The major alar cartilages form the medial and lateral borders of the nostrils. When the muscles of our nose contract and relax, the major alar cartilages, they dilate and constrict the nostrils. That's why when you smile, sometimes the nose will start to widen up and come back down. Anyways, because those muscles contract and relax and use. All right. Finally, there's about maybe 3 or 4 smaller pieces of cartilage that we find behind, posterior to the major cartilages, which are called the minor alar cartilages. Now, it's made up of hyaline cartilage. It's pliable hyaline cartilage. So this is what makes the framework of the external nose a little bit more flexible. This is what it allows for that. All right. The external nares or nostrils. So nostrils lead into the cavities so the nostrils, they lead into the cavity to the nasal vestibules, right? This is the area, so if you were to take your finger and stick it up, this is the area that your finger would be in place. Okay? That's the vestibule, the nasal vestibules. The lower half of each nasal vestibule, it's lined with skin that continues to the skin of your face. Now, this skin has a lot of hairs over here, along with sebaceous glands and sweat glands as well. And again, they secrete their contents onto the surface. Now, the upper lining of each nasal vestibule, it transitions into the mucous membrane. And again, that mucous membrane, it will continue deeper into that nasal cavity. Now, deeper into the skull, beyond the region of the vestibules, we have the internal nose. This is also called the nasal cavity. Now, it's a much larger space in the anterior part of the skull. It's going to be positioned inferior to the nasal bones and superior to the oral cavity, and it forms the vast majority of the nose. Now, the bony and the cartilaginous framework of the nose, it helps keep the vestibules and the nasal cavity open. Okay, and the medical term that we use to describe open or unobstructed is patent. P-A-T-E-N-T. P-A-T-E-N-T means open. This is a medical term for that. You should be aware of that. You have to know this. Anteriorly, the nasal cavity, it merges with the external nose, and posteriorly, the internal nose, it's able to connect with the pharynx through 2 openings that are called the internal nares. Internal nares. Another term that we use to describe the internal nares are the choanae. C-H-O-A-N-A-E. Choanae. C-H-O-A-N-E. So when you look at this next photograph over here, essentially what we see are here. Look, here's the septal nasal cartilage right over there. Okay, that's the septal nasal cartilage. Now, the lateral nasal cartilages are these parts over here, this side there and this side there. Now, a lot of the times, again, during cosmetic surgery, this is, especially if you have a big hump, a lot of times is this that's being removed. Okay, they end up shaving this part of the cartilage down. And then the other part of it is this, they'll end up shaving some of this or reshaping some of this. And this is the minor parts. This is what gives the flexibility to the nose. And here's the nasal bone. Now, they don't really break this bone, okay, when they're doing rhinoplasty. Essentially, it might be cracked or then they start to shave down some of this bone also. They can mold it with special instruments like a piezo machine, ultrasonic piezo, they call it. Yeah, that's all it is. Now, when you look over here again, here is the external nares over here, okay, external. And this is the nasal vestibule. Again, remember what I said, if you stick your finger up, this is that area that it occupies with. Then you have the nasal conchae. And again, they get divided into superior, middle, and inferior. These parts over here, what they do is they just kind of help speed up, they increase the pressure and push the air down faster. In addition to that, they're lined with mucous membranes and again, blood vessels, which end up filtering that air as well as warming it up, heating it up. Okay, so again, on cold days like today, you need that warm air. Again, the lungs, they don't deal with cold air very well. It needs to be warmed up. So again, cold days like today, when you were to go out, if you were to go out, it may be a little bit more difficult for some people to breathe. Again, why? Because again, cold causes constriction of blood vessels. When the blood vessels constrict, not enough oxygen is able to pass through. So that kind of explains that. So again, the paranasal sinuses, again, the nasal cavity gets divided into I think I told you already this, but yeah, by the internal nasal septum into right and left halves. So again, the septum is formed by the septal nasal cartilage. And I told you that I told you all this information already. I told you, we looked at the conchae also. So again, it subdivides this cavity into, again, these 3 passages. This is what I was telling you about over here. This is this area. So what are they doing? Again, there's a superior, middle, inferior part. They just help speed up the air. They help increase filtration and warming up the air. Also, it helps with the sense of smell, all right? Also, it helps deepen your voice, again, so it resonates. It acts as a resonating chamber for sound. So when you're cold, your voice sounds funny. That's the reason why. Why? Because again, if this part over here, if it's resonating sound and it's filled with mucus and fluids because of an infection that you have, then that air is not going to be going up there. So again, your voice is not resonated well. Moving down into the throat, okay, into your pharynx. All right, so again, the throat, not only does it act as a passageway for air, but also it allows food to go down as well. Your throat also acts as a chamber, a resonating chamber for speech when we speak. In addition to that, it holds the tonsils as well. In addition to that, there's also taste receptors that are found within the throat as well. Now, the throat, as I showed you earlier, we can divide into 3 different parts. You have the nasopharynx, oropharynx, and the laryngeal pharynx. And the nasopharynx contains your tonsils over here, the adenoids. The oropharynx, it contains the lingual tonsils, okay, as well as the palatine tonsils. And then we have the laryngeal pharynx, which is found close to the larynx. Cranial nerves 9 and 10 are what innervate the pharynx. So again, if you have problems with the swallowing, for example, that's an issue. Then again, they may be looking at these 2 nerves. All right. So again, H1N1 virus, influenza. We're in the midst of the flu season right now. Also, mind you, the numbers are not very high for flu. They are rather high for. Well, actually, let me just put it this way. They're not being diagnosed as much because it's being overshadowed by coronavirus right now. So again, the common cold is what's referred to as coryza, okay? Coryza. This is the common cold. Again, rhinoviruses, they're responsible for about rhinoviruses are responsible for about 40% of the colds that adults end up getting. Seasonal influenza. All right, so it's like a cold, but it comes with fever, a headache, muscle aches, and it could develop into pneumonia. Okay, so it could kill. Okay, so flus are bad. H1N1, right? This is all. This is also called what you guys remember. It's the swine flu. So again, in addition to all these things that I described before, you end up having vomiting and diarrhea with that. So bad stuff, not good. Bad stuff. All right. Now moving on to the larynx. All right. Lots of larynx. A lot of people also call it the laryngopharynx, or again, your voice box. All right. So the voice box, right? It connects with the laryngopharynx, with the trachea. So these three things, they're all there in a series. All right, we're going to talk about the different the parts that make up the larynx, okay, the cartilages. So of the paired cartilages that are there, the arytenoid, A-R-Y-T-E-N-O-I-D, arytenoid cartilage. These are the most important ones because they influence the not only the position, but also the amount of tension that's placed on the vocal cords. Okay, now vocal cords are also called vocal folds. Okay, vocal folds, F-O-L-D-S, folds, like when you fold your clothes. The extrinsic muscles of the larynx, they end up they connect the cartilages to other structures in our throat. The intrinsic muscles, they connect the cartilages to one another. The cavity of the larynx is the space that goes from the entrance of the larynx to the inferior border of the cricoid cartilage. Cricoid cartilage, C-R-I-C-O-I-D, cricoid cartilage. Now, the position of the cavity of the larynx above the vestibular fold is called the laryngeal vestibule. The part of the cavity of the larynx below the vocal folds is called the infraglottic cavity. Infra means below, infraglottic, glottis, below the glottis, infraglottic cavity. We also have our Adam's apple. And Adam's apple, commonly we call it what? It's referred to, Adam's apple is actually medically called the thyroid cartilage. Or anatomically, in anatomy, it's referred to as the thyroid cartilage. It's the largest cartilage of the larynx, and it's made up of two fused plates of hyaline cartilage that forms the upper anterior and lateral walls of the larynx. And this is what ends up giving it the triangle shape. The anterior junction of the two plates ends up forming this Adam's apple. Okay, the anterior junction of the two plates, it forms this the laryngeal prominence, right, which is more commonly known as the Adam's apple. Now, above this, excuse me, above the prominence, we end up having this V-shaped notch. Okay, above the prominence, we have this V-shaped notch. Again, you can palpate that with your fingers. The ligament that connects the thyroid cartilage to the hyoid bone just superior to that is called the thyrohyoid membrane. Thyrohyoid membrane. Again, thyrohyoid. Thyro means thyroid, hyoid means hyoid bone. Okay? And again, membrane. And it's a ligament. What does ligament do? It connects the thyroid cartilage to the hyoid bone. Okay, that's how you get thyrohyoid, the name. Now the epiglottis, it's a leaf-shaped piece of elastic cartilage that's covered with, or we should say, lined with epithelium. Now the stem of this epiglottis is it's a tapered off inferior portion that attaches to the anterior rim of the thyroid cartilage. This is what holds the epiglottis in place, right? Is the stem. The broad superior, the leaf-shaped portion of the epiglottis, it's unattached, and it is able to move about up and down, and it acts like a door. And that's what it's actually doing. When you eat, it closes up so food and water doesn't go into your trachea. And when you are eating, when you're eating, it closes that. It prevents the food from going to the trachea. Now, when you're not eating and you're breathing, then it opens up to allow for air to move in and out. Now, during swallowing, again, so when you swallow, the pharynx and larynx, they both move upwards. Okay, so when the pharynx is elevated, it widens. Again, it widens to receive water and solids, foods that we eat or drink. Now, elevation of the larynx, it causes that epiglottis to move down, and it ends up forming, it forms a lid to cover the glottis. Okay, and it closes it off. The passage through the larynx is called the glottis. The glottis is made up of folds of mucous membrane. We have the vocal folds, and your vocal cords in the larynx, and also the space, the area between them. The space between them is called the rima glottitis, right? When you look over here, what do we have over here? Again, your thyroid gland, and this is the parathyroid glands that we learned about before. So this is that stem of the epiglottis. This is that leaf-shaped portion. So this part, it ends up, so it can move back and forth, back and forth. Imagine this is three-dimensional. If you had a side view, it'd be moving back and forth. So it would fall forward, and then when you're breathing in, it comes upward like that. When you're eating, it falls straight forward, and it covers the glottis. Okay? This is the thyroid cartilage over here. This is what forms the Adam's apple over here. Okay, this is your thyroid cartilage. Okay, or the laryngeal, prominence over here. What do we have after that? That's your cricothyroid ligament over here. You have your cricoid cartilage right over here. Okay, this is the part that I told you apply some pressure to. This posterior view of it. You apply pressure over here when you need to intubate somebody. That's all trachea over here, tracheal cartilage. That's the hyoid bone over here. Okay, and this is that thyroid membrane. Okay, thyroid membrane is over here. What else? All right, I think that's good. Let's move along. We don't need to look at that. All right, here. So when you look over here, here's that laryngeal vestibule right over here. Okay. Here's that infraglottic cavity right over here. So not here, perfect. You can see them better in this picture. So here's that epiglottis. Okay, this is the back view, posterior view. Here's the front view over here. So this thing is going to fall forward. Now, here's a corniculate cartilage, by the way. When it forms forward, you can see this. So here, this is a superior view. Now we're looking down on it. When this falls forward, it covers this opening. So what is this? The opening is actually called the glottis, right? Now the space over there, beyond that, that's the rima glottitis. All right. Okay. Here's that stem that you can see also over here. Right, this is the best picture, I guess, to look at. Moving on to the larynx. So the cricoid cartilage, it's a ring of hyaline cartilage that forms the inferior walls of the larynx. It ends up being attached to the first ring of the cartilage of the trachea by the cricotracheal ligament. Cricotracheal ligament. The thyroid cartilage is connected to the cricoid cartilage by the cricothyroid ligament. Cricothyroid ligament. Okay, very easy. It's just talking about the 2 points where it's being attached. One's going from the cricoid to the trachea, one's going from the cricoid to the thyroid. The cricoid cartilage is one of the landmarks for making a trachea. It's a landmark that you use to identify where you want to make an opening for in a procedure that's called a tracheotomy. Tracheostomy, when you're doing a tracheotomy. The paired arytenoid cartilages that we have, okay? The arytenoid cartilages. So again, they're in shape, they kind of look like a triangle. Again, this is also mostly hyaline cartilage. We find that posterior, at the posterior superior border of the cricoid cartilage, and they end up forming a synovial joint, okay, with the cricoid cartilage. This provides them with a wide range of mobility. Next, we have a pair of corniculate cartilages. Those are again, those two horn-shaped pieces of cartilage that we saw. So again, they're found at the apex of the cartilage. Here we go. This is that corniculate cartilage. Kind of looks like a horn. Next, what do we have? The cuneiforms. All right. We also have a pair of cuneiforms. Again, they're club-shaped. Again, it's elastic cartilage that we find anterior to the corniculate cartilage at the lateral aspect of the epiglottis. All right. Laryngitis. What's laryngitis? Laryngitis is just inflammation of the larynx. Most commonly, it's caused by, could be a respiratory infection, or again, irritants like cigarette smoke or hookah smoke. Now, when the vocal folds end up being inflamed, then we may lose our voice, or again, our voice becomes it ends up being horsey. We get a hoarseness that results, and that's what it's doing is interfering with your the vocal folds, or again, sometimes it'll cause them to swell. They swell so much that they're not able to vibrate easily. All right, cancer of the larynx. All right, don't smoke cigarettes. Again, you find it nearly always in people that smoke, right? So again, you want to save yourself from throat cancer, don't smoke. All right. Again, it could be pain swallowing, radiating pain. So the pain sometimes goes from the throat and it radiates to your ear. Your voice could be hoarse. Again, don't smoke. I'll just leave it at that. It's treatable, yeah, not always, unfortunately. All right, so the mucous membrane of the larynx forms two pairs of folds, right? There is a superior pair that's called the vestibular folds, and these are the false vocal cords, right? And there is an inferior pair that's called the true vocal cords, okay? Now the space between the vestibular folds, we call that the rima vestibulae. Rima vestibulae. The laryngeal sinus, the laryngeal ventricle, okay, the sinus is the lateral expansion of the middle part of the laryngeal cavity. Superiorly, it's bordered by the vestibular folds, and inferiorly, it's bordered by the vocal folds. Okay, so the vestibular and vocal folds are the boundaries for it, superior and inferiorly. Now, the vestibular folds, they don't act to produce your voice. So if they don't make sound, what are they there for? What do they do? Well, when the folds, they come together, they function in holding our breath against against the pressure that's in the thoracic cavity. So again, when you kind of strain, when you want to lift something heavy, and you brace yourself, this is what they're doing. That's when they kick in. That's when they start to work. All right, next part over here. All right, air passing through the larynx, it vibrates the folds. As the folds start vibrating more and more, it produces sound. Now, the variations in the pitch of the sound, it ends up being real. Again, it's tied to the amount of tensions that's produced in these vocal folds. So here we go. Here's that rima glottis that you'll see over here, right? That's all rima glottis that you see over here. And over here you have the vocal folds right over here. Okay, here's the vestibular folds over here. This is the corniculate cartilage, superior support, and here's that epiglottis over here. All right. Again, so you can see it closed and open, closed and open over here. And amount of how much air and tension, these are, there's put on this. As wind moves past it, produces different pitches of sound. Moving along to the trachea. All right, so the trachea, again, commonly, most people call it the windpipe. It's a passageway for air to transport before it branches off again. It's about 12 centimeters, which is about 5 inches long, and it's perhaps 2.5 centimeters or about maybe an inch wide. Yeah, between 2.5 to maybe 3.5 centimeters in diameter. Where do you find it? All right, so it's located anterior to the esophagus. The esophagus is in the back, trachea is in the front. It starts at the larynx superiorly, and it extends inferiorly to about the level of the superior border of the 5th thoracic vertebra, so about T5. At that point, it's going to start to divide into the right and left main bronchi. The layers of the tracheal walls, they form they form different layers. Okay, the layers of the tracheal walls, they form deep layers. So again, when you go from, it's quite a bit. So when you go from very deep all the way to superficial, innermost, outmost. Innermost, we have the mucosa, all right? So the mucosa of the trachea, it's made up of an epithelial layer of pseudostratified ciliated columnar epithelium. Okay, there's also an underlying layer of lamina propria, lamina propria, that holds the elastic and reticular fibers. Now, the epithelium, it's made, again, as I said, it's made up of ciliated columnar cells. In addition to that, there's also goblet cells. And these goblet cells end up reaching to the surface, luminal surface. In addition to that, basal cells. All right, so these cells, they give you the same level of protection. In other words, as that mucus is produced, it's trying to trap foreign particles, foreign debris, pathogens. It's like a glue that's there to just kind of trap it off. Once it traps things, why? Because it doesn't want these debris to go deep into the lungs. That's a problem when that happens. So again, when it gets trapped, then it pushes it up into your throat, and then you spit it out or you swallow it the vast majority of times. Mostly it's swallowed into the stomach. All right, the fibromusculocartilaginous layer, there's about 16 to 20 incomplete C-shaped horizontal rings, okay, that make them up. The rings are stacked one on top of the other, and they're held together by dense connective tissue. So again, you can feel them, if you feel the surface of your skin below your larynx, you'll be able to feel them. Now, the open part of this C-shaped cartilage, it faces towards the back. It faces posteriorly towards your esophagus. The closed part, that's facing anteriorly. Also, so again, so they're lined with this with the fibromuscular membrane. Now, within this membrane, we have these transverse smooth muscle fibers, which are called the trachealis muscle. In addition to that, there's also elastic connective tissue. And this allows the diameter of the trachea to change during inhalation and exhalation. And again, this is important in maintaining enough pressure for gas exchange to take place. Again, these C-shaped rings, these cartilaginous rings, they end up providing, they're semi-rigid, they're not very hard. And again, this helps ensure that the trachea stays open all the time, that it stays patent. Again, you don't want the tracheal walls to collapse on themselves. If that were to happen, again, ear is obstructed, you cannot breathe. Now, the superior, the most superficial layer, okay, the superior most superficial layer of the trachea is called the adventitia. And it's made up of areolar connective tissue. And again, it's joining the trachea to the surrounding tissue. So when you look over here, essentially what we have going is here. This is the part that we're looking at. This is that trachea. So you look at these C-shaped discs. They're just all stacked one on top of the other. Maybe there's about 20 of them. Maybe there's about 15 of them over here. This is the cornea, this part over here. At the cornea, the trachea ends up dividing to right and left main bronchus. So this is the left main bronchus, this is the right main bronchus. And then each one of these, each one of these bronchus then divides into, lobar branches. So here's a lobar branch over here. And these lobar branches, they divide in, we're going to look at the hierarchy, but they go into segmental branches, we'll just kind of go through this multiple levels of it. So again, this is a cross section. This is the front of your body, this is the back of the body. In other words, this is anterior, this is posterior. So when you look, there's part of the thyroid cartilages here, the left and right thyroid cartilages. And this is the trachea over here, the tracheal cartilage you can see. C-shaped. See, there's nothing over here, C-shaped, and it's just membrane over here, fibromuscular membrane. Now behind that posterior, this is the esophagus, your food tube. This is where food travels through. All right. At the superior border of the fifth thoracic vertebra, the trachea, it divides into a right and left primary bronchus. Right and left primary bronchus. In other words, they're going to, this eventually goes into the right lung, the left one eventually goes to the left lung. Now the right main bronchus is a little bit more vertical and shorter than the left. Okay. Now, if you were to, by mistake, kind of swallow something and it were to travel down the trachea, it'd probably fall on the right side than the left side because it's more vertical. The main, so similar to the trachea, the main bronchi, they also have incomplete rings of cartilages, and also they're lined with the same type of cells, pseudostratified ciliated columnar epithelium. Again, they're there to produce mucus. Now, as I told you before, the point where the trachea divides into the right and left main bronchi, we call that the carina. Okay, let me show you that. That's right over here. This is that carina, this part. All right. The main bronchi, it divides into smaller parts. Okay, and the first of that are the secondary bronchi, or the secondary bronchi. They're also referred to as the lobar bronchi, lobar, L-O-B-A-R, lobar bronchi. Again, they end up going, there's the lobar bronchi, there's one for each lobe of the lung. Now the right lung, remember what I told you, right lung has 3 lobes, left lung has 2. Now the lobar bronchi, they continue to branch into smaller bronchi called the segmental or the tertiary bronchi. And they supply specific bronchopulmonary segments within the lobes. Now, these segmental bronchi, they divide into bronchioles, okay, which are small bronchioles. All right, the nerve supply for the lungs comes from the pulmonary plexus. The pulmonary plexus is formed by branches of the vagus nerves as well as the sympathetic trunk. All right, bronchioles, they will branch repeatedly, and they're going to start branching until they end up getting to terminal bronchioles. Now, over here, these terminal bronchioles, they contain Clara cells, C-L-A-R-A, Clara cells. These are columnar, non-ciliated cells, cells that you find among the epithelial cells. Clear cells, they think that they help protect against bad things that may be inhaled, toxins and carcinogens. They also produce a certain amount of surfactant. We'll talk about surfactant a little bit later. They also can function as stem cells. So let's look over here. So what do we have? From the larynx, we have the trachea, right? From the trachea, you have the main bronchi. From the main bronchi, we have the lobular bronchi over here. This is going over here. It's one to each lobe. One there, lobular bronchi. From the lobular bronchi, so again, 1, 2, and 3. Lobular bronchi, then you have the segmental bronchi. These are the segmental bronchi that you see, right? In the segmental bronchi, they go to the bronchioles. The bronchioles then go into the terminal bronchioles. That's all there is to it. And all right, again, this is a cross section. Again, this is that lung, that smoker. They made a frontal plane of the corona to reveal the tissue. Notice how vascular this is. Highly, highly, highly vascular. Number of miles or kilometers of blood vessels are here. You cannot imagine how extensive it is, and it's just absolutely beautiful. The arrangement of it, if you were to look at it. Okay. Let's talk about lungs now. Lungs. Now, the lungs, they're a pair of cone-shaped organs that we find within the thoracic cavity. They're separated from one another by the heart and other structures that we have within the mediastinum. And again, thankfully, because of this, because they're separated and they're in two different areas, God forbid if you were to end up receiving some type of trauma, severe trauma, and lung work to collapse, the other one would not be affected because of the separation. Now, each lung is separated by a double layer membrane. And you guys learned about this in the very first chapter, which is called the pleural membrane. Medially, the left lung also contains a concave area. Okay, we call that the cardiac notch, and I showed you that in the photograph earlier. This is where the apex of the heart is going to kind of push into. So again, because of the heart being more towards the left side, the left lung, therefore, is slightly smaller than the right side. The right lung is thicker and is also broader. With that said, it tends to be a little bit shorter than the left lung because the diameter is a little bit higher on the right side than it is on the left side. The reason the diaphragm is a little bit higher on the right side than it is on the left side is to help make room for the liver. Liver is found underneath the diaphragm on the right side. All right, clinical, pneumothorax, hemothorax. If air gets into the pleural cavity, we call that pneumothorax. If blood get there, we call that hemothorax. If both blood and air get there, we call that a hemopneumothorax. All right. A collapsed lung, the term we use for that is atelectasis. Okay, atelectasis. A-T, A like apple, T like Tom, E like elephant, L like Larry, E like elephant, K like kite. No, hold on. Let me start that off. Atelectasis. A like apple, T like Tom, E like elephant, L like Larry, E like elephant, C like cat, T like Tom, A like apple, S like Sam, I like India, S like Sam. All right, atelectasis. Again, this is just a collapsed lung. All right, what's next? All right, when you look over here, what do we have? This is the base of the lungs. This is the apex of the lungs, right? This is the costal surface of the lungs. The hilum is the part where the primary bronchi enters the lung. That's the hilum. The point where, here, this part right over here, that's the hilum. Or collectively, it's called the hilus. Okay, this part here, where all the tubes enter and exit the lungs. We have blood vessels and the bronchi entering. Singular, hilum. Plural, hilus. H-I-L-U-S. It's a Greek term, Greek root. Okay. Both lungs have an oblique fissure, and it extends inferiorly and anteriorly. The right lung also has a horizontal fissure, right? The oblique fissure in the left lung, it separates the superior lobe from the inferior lobe. In the right lung, the superior part of the oblique fissure separates the superior lobe from the inferior lobe. The inferior part of the oblique fissure, the inferior part of the oblique fissure separates the inferior lobe from the middle lobe. That ends up being bordered superiorly by the horizontal fissure. Look at the pictures and you'll be able to understand, you'll be able to see these. Each lobe receives its own lobar bronchus. So the right main bronchus gives rise to 3 lobar bronchi called the superior, middle, and inferior lobar bronchi. The left main bronchus ends up coming to the superior, inferior, to the superior and inferior lobar bronchi. Now within the lungs, the lobar bronchi, they give rise to the segmental bronchi, and there's about 10 segmental bronchi within each lung. The segments of the lung tissue that each segmental bronchus supplies, we call that the bronchopulmonary segment. Bronchopulmonary segment makes sense, right? Segments of lung tissue that each segmental bronchus supplies. Broncho, you're connecting the two terms, bronchus and pulmonary. The bronchial and pulmonary disorders, like an abscess, they end up being localized in a particular bronchopulmonary segment. They could end up surgically removing this without disrupting too much of the surrounding tissue because of these segments that are there. Each bronchopulmonary segment of the lung, it has a lot of small compartments that are called the lobules. Okay, lobules. Each lobule ends up being wrapped in elastic connective tissue, and it contains lymphatic vessels. It'll have a lymphatic vessel. It has an arteriole, a venuole, and a branch from a terminal bronchiole. So again, we have very, very small structures over here. Now the terminal bronchioles, they subdivide into microscopic branches called respiratory bronchioles, right? The terminal bronchioles, they divide into microscopic branches called respiratory bronchioles. From these respiratory bronchioles, they have alveoli, okay, that end up forming the walls. Now, because the alveoli, this is where the gas exchange is taking place between the respiratory bronchioles within the respiratory zone of that respiratory system, of the respiratory system. Now, as the respiratory bronchioles penetrate deeper into the lungs, the epithelial lining, it changes from simple cuboidal to simple squamous. Makes sense, right? The deeper you go, the less room there is going to be. Therefore, the tissue is starting to condensing. So you have this transition. Also, deeper, you're going to have the exchange of gases that will take place. This is where, again, the respiratory zone is going to be. Now, the respiratory bronchioles, they divide into several alveolar ducts. Okay, the alveolar ducts, they contain, they're made up of a simple squamous epithelium. Now, the respiratory passageway from the trachea to the alveolar ducts contain about 25 levels of branching. Okay, so again, in other words, this branching takes place about 25 times, going from large to small, it gets small 24 times. Okay? Again, from the trachea, you go to the main bronchus. Main bronchus, you go to the lumbar. Lumbar to the segmental, and on and on and on and on. Okay, all the way down to the alveolar ducts. So, when you smoke, most of these different parts, what ends up happening is these bronchioles get affected, right? The ducts the alveoli get affected. They get damaged. The epithelial cells, they get paralyzed. Believe it or not, the epithelial cells get paralyzed. Now, when they're paralyzed, those ciliated cells, they're no longer able to move. Now, remember, when they move, what's on the surface of them? Mucus. And that mucus ends up being pushed into our throat, as I said earlier. So when you're smoking and all the toxins end up damaging those ciliated cells, they're not able to move. And when they're not able to move, the mucus just stays there. As the mucus stays there, it starts to accumulate more and more mucus. And again, all that trapped debris, it also starts to accumulate. Now there's a risk of all that gunk falling inside deeper. This is where the problems start. Again, this is where cancer takes place. All right, nice healthy lungs that when you look over here, right? This is the costal surface, this is the apex, this is the base. This is the hilus over here, or the hilum. Right hilum, left hilum, where blood vessels and airway and the primary bronchus that enters. Here's the anterior surface they're showing you again, close up. Again, over here, they're just showing you the different levels of branching. Remember, I told you it's up to 25 levels of branching that can take place. So be sure you go through and look at it, and it'll show you which parts each one ends up going to. So you can see this part's going over there, this part goes over here. This part is mostly for over here. When you look at 4 and 5, it's coming there and there. And the posterior portion is coming through this part over here, 8 and 6. All right. All right, so as we come, again, this is that terminal bronchiole. And this is that terminal bronchiole. It ends up coming to the respiratory bronchiole. Now, the respiratory bronchiole, we said, comes and terminates at what? The respiratory or the alveolar ducts. And then the alveolar ducts, right over here, are connected to the alveoli. When you look, alveoli, again, you have these tiny little compartments over here. And outside it, it's surrounded by blood vessels. These are the pulmonary capillaries. So when air comes in, it crosses through from this part. It ends up being picked up over here into these blood vessels. And the carbon dioxide that's in the blood vessel, it goes inside over here. Then when you breathe out, these things, they deflate, and then it pushes it back up where air moves out. All right? So again, remember, from the respiratory bronchioles to the alveolar ducts, from the alveolar ducts, it ends up going to the alveolar sacs. All right. So moving on to the alveoli. Let's talk about them. Right. So around the circumference of the alveolar ducts, we have many alveoli and the alveolar sacs. An alveolus, this is a cupped shaped outpouching, as you saw in the previous picture, that's lined by simple squamous epithelium. Simple squamous. You have a simple single layer of cells. You have to have that because you want to have gas exchange take place over here. It's supported by a thin elastic basement membrane. The alveolar sac, it's made up of 2 or more alveoli that share a single opening. The walls are made up of 2 types of alveolar epithelial cells. Okay? The walls are made up of 2 types of cells. You have type 1 and type 2 cells. Type 1 alveolar cells, these are the predominant cells. They're simple squamous epithelial cells, and they form a near continuous lining of that wall. And these are the main sites of gas exchange to take place, would be at these alveolar walls. Like the type 2 cells, which are also called the septal cells, They're far fewer in number, and we find them between the type 1 alveolar cells. Now, the type 2 cells, they're cube-shaped, they look more rounded, and they have a free surface that has a lot of microvilli that's there. Now, what do? They secrete a fluid. What's that fluid called? That fluid is called surfactant. S-U-R-F-A-C-T-A-N-T. S-U-R-F-A-C-T-A-N-T. Surfactant. Very, very, very important. This is what keeps this sac from sticking to each other. Now, think about it. Let me give you a real world example of that. If you were to take a balloon and blow air into that balloon, fill it up, and then just let all that air out and blow it up again and let it out. You could only do it a few times, a handful of times. Eventually, what's going to end up happening is it's going to become harder and harder for you to blow up that balloon. Why? Because the insides of the balloon is going to start to stick to each other, right? And the same thing happens over here. It starts to stick to each other. So what was the solution for that? Well, the solution for that was to place some cells here, and that would produce some surfactant that would not let these, it would make it less sticky, okay, and slippery, so they can open up very easily. Okay, perfect design. All right. Moving along, next part. So the exchange of the gases, oxygen and carbon dioxide, between the air and spaces within the lungs and the blood vessel, it takes place by diffusion across the alveolar and capillary walls. Again, the alveolar and the capillary walls, they form the respiratory membrane, okay? Respiratory membrane is what? Alveolar and capillary wall. Now, from the extending from the alveolar, extending from the alveolar airspace to the blood plasma, the respiratory membrane is going to be made up of 4 layers. There's a layer of type 1 and type 2 cells and associated alveolar macrophages that constitute the alveolar wall. Now, there's an epithelial basement membrane that's underlying the alveolar wall, and there's the capillary basement membrane that's usually fused with the epithelial basement membrane. Lastly, the endothelial cells of the capillary wall, even though they have several layers, that membrane is very thin. It's maybe 0.5 times 10 to the minus 9. It's about 1/16 of the diameter of a red blood cell. If you can imagine that, they're tiny. So the thinness, this is what allows for the rapid diffusion of gases. Now listen to this. Each of your lungs has about 300 million alveoli. 300 million. Now, if you were to open them all up and measure it, the surface area would be about 70 square meters. That's a huge number. 70 square meters. Think about that. In each lung. Let's talk about blood supply and patency. Now, the bronchial arteries, which branch from the aorta, they deliver the oxygen blood to the lungs. This blood mainly passes through the muscular walls of the bronchi and the bronchioles. There's no connection between the branches of the bronchial arteries and branches of the pulmonary arteries. Now, most blood, it returns to the heart by, as we know, the pulmonary veins. Now, some blood, however, it drains into the bronchial veins. All right. Now, aside from surfactant, which helps keep the alveoli open, we also talked about the cartilaginous framework within the nose that ends up keeping the nose open. We talked about the C-shaped rings that help keep the pharynx open. We talked about the cartilages of the larynx that help keep it open. We talked about the smooth muscle within the bronchioles that also help keep it open. With that said, there's a lot of factors that can still compromise that patency. Now, that could be injury, okay, injuries to the bone and cartilage. It could be, for example, a deviated nasal septum. They could be nasal polyps. It could be inflammation of the mucous membrane. It could be spasms of smooth muscle. Or again, it could just even be a deficiency of surfactant that's being produced. Now, when you look over here, again, this is an alveolus, and you can see blood vessels over here. And this is that respiratory membrane, very thin, huh? Super thin over here. This is that type 2 alveolar cell that you find between the type 1 cells. And what are these type 1 cells doing? They're producing, the type 2 cells. Type 1 cells, they form what? The respiratory membrane, okay? Type 2 cells we find between the type 1 cells. They produce surfactant. So as they're producing surfactant, these walls, they don't stick up. It prevents them from sticking onto each other and easily allows them to open up as air comes in. There's also macrophages over here, alveolar macrophages. These are just white blood cells. They're there to clean up debris, junk, break it down, or any toxin, anything harmful. They're there to eat that up. It's a lot of protection that's there also for you. All right, let's talk about mechanical ventilation, okay, pulmonary ventilation, or the mechanics of pulmonary ventilation, breathing. So the first process of breathing, okay, and we call this pulmonary ventilation, is made up of inhalation, which is an inflow of air, and exhalation. Exhalation or exhaling is an outflow of air. And this is the exchange of air between the atmosphere and the space in the lung, okay? Ventilation, right, is just the exchange of air between the atmosphere and lung. Internal respiration, right? Internal respiration. This is exchange of gases between the systemic capillaries and the tissues of the cell. This is when blood loses oxygen and it picks up carbon dioxide, right? That's internal respiration. All right, let's see. Internal respiration. All right, external respiration. Again, that's pulmonary respiration. What do we say? This is where gas exchange is taking place between the capillaries and the respiratory membrane. Across the capillaries, the pulmonary capillaries across the respiratory, inside the alveoli and the pulmonary capillaries. Exchange of carbon dioxide that takes place there. In other words, blood loses carbon dioxide and blood gains oxygen, right? Make sure you understand this. All right, so before each inhalation, the air pressure inside the lungs is equal to the pressure of the atmosphere, right? So if the pressure is going to be equal, then you have a net effect. Nothing's going to happen. So in order for air to flow into the lungs, the pressure inside the valve, it has to decrease. So it becomes lower than the atmospheric pressure. How does that happen? Well, the lungs, they have to expand. Now, the first step for this to occur is that the alveoli, they need to expand within the lungs, right? So during normal quiet breathing, this involves contraction of breathing muscles also. We'll talk about that. Now, when you come to exhalation, this is achieved by the pressure gradient, okay? The pressure in the lungs, it has to be greater than the pressure of the atmosphere. So again, in normal exhalation during quiet breathing, there's two factors, the recoil of elastic fibers and also the inward pulling of surface tension. So when the respiratory muscles relax, okay, the ribs, they collapse. As the ribs collapse, they squeeze on the lungs. As they squeeze on the lungs, air moves out. In addition to that, the diaphragm, it also pushes up. As the diaphragm pushes up, it also starts squeezing the lungs from its base. And the opposite is happening over here in inhalation. In inhalation, the diaphragm moves downwards, okay? Diaphragm will contract. As the diaphragm contracts, what happens? Diaphragm contracts, the area inside increases, the inferior portion increases. Therefore, the base of the lungs could expand more. Also, the breathing muscles, your external intercostals, internal intercostals, they end up contracting and lifting the thoracic cavity up. As the rib cage moves more forward, then the lungs also can expand easily. This is what creates that the chamber. So here you can see the internal and the internal intercostal muscles over here, and the external intercostals over there. The directions that they move or they play. So when you inhale, the internal intercostals, what are they doing? Internal intercostals, they're lifting up the ribs off of the lungs. During exhalation, the internal intercostals, they start to bring the lungs back downwards. They're starting to push on the lungs to decrease that area inside, to squeeze the lungs for the air to push outwards. All right. We learned in the previous chapters, okay, the part for in the brain that controls breathing, okay? Breathing is controlled by the brain. And we talked about the medulla oblongata and the pons that control the breathing rate. So you can revisit that lecture because we talked about the dorsal respiratory group, and also we spoke about the ventral respiratory groups and what they do, how they regulate the breathing in conjunction, working with the pons. All right, yeah. So again, revisit the lecture from the slides before. Very quickly, your basic rhythm for breathing, again, it's controlled by the medulla, okay, by the respiratory centers within the medulla. 2 seconds inhalation, 3 seconds for exhalation. This is the rate that it's working with. It's working on a 5-second cycle. So if you look at it, it's about anywhere from 10 to 12 times a minute. This is normal breathing. Now, during quiet breathing, during normal quiet breathing, neurons in the dorsal root ganglia, not dorsal root ganglia, what is it? The dorsal respiratory group. The dorsal respiratory group. This is the inspiratory area. They end up producing impulses that help for contracting the diaphragm, as well as the intercostals. And for the ventral respiratory group, they end up remaining inactive during this quiet breathing. Okay. Now, it's during that forceful breathing, the DRGs, they activate, and the VRG impulses, it ends up increasing the contractions for the accessory muscles in order for breathing to take place. Okay, so forced activity will do that. Go through the schematic, please. It kind of explains both the ventral and the dorsal respiratory groups and their functions. Again, working on during quiet breathing, normal breathing. This is a 5-second cycle of inhaling, exhaling. Okay, inhaling, exhaling, 5-second cycle. 2 seconds to take air in, 3 seconds to breathe it out. Now over here, we're talking about what happens when you force it, when you're running really hard or you get really scared. How are these modified? This is what ends up happening. When you're overstimulated, it alters forceful, both inhalation forcefully and exhalation forcefully. Moving along to PONS, okay, the PONS respiratory group, or the PRG. Again, they used to call it the pneumothorax area. We find it within the upper pons, and it sends signals to the dorsal respiratory group to stop, okay? Inhibitory signals. When the pontine group is more active, your breathing rate tends to be faster. What about cortical influence of the brain? All right, the cerebral cortex has connections with the respiratory center. Okay? Therefore, we can alter our breathing also. So we can voluntarily either start breathing a little bit faster or breathe slower or hold our breath or whatnot. The voluntary control, it helps us I don't know, you want to go swimming, okay, or you're taking a shower. This is what allows you to hold your breath and not breathe while you're within water. Right? Your phrenic and intercostal nerves, they also, again, without them, you're not going to be able to breathe. So they play a huge role in breathing. Nerve impulses from the hypothalamus as well as the limbic system, they also stimulate the respiratory center. So again, when you're emotional, right, it's going to alter your breathing. Again, think about it. Girls, boys, you see your boyfriend or girlfriend or wife or husband, your breathing starts to change. All right? Why? Because again, limbic system. Or you get scared, breathing starts to get changed. Why? Limbic system. All right, moving along. Chemoreceptors, they end up monitoring the levels of carbon dioxide, hydrogen ions, as well as oxygen. And also, again, they end up providing input to the respiratory system. It processes information and sends that information to the respiratory system. Now, central chemoreceptors we find located within the medulla oblongata. The peripheral chemoreceptors we find throughout the body, or primarily you're going to find within the aortic bodies and the carotid bodies. Okay, so the arc of the aorta as well as the carotid arteries are where they're found. And again, they're sensitive to changes in oxygen, in acid, and carbon dioxide in the blood, and hydrogen ions, oxygen and carbon dioxide in blood. Now, so vagus nerve, again, is huge role in breathing. Just remember that vagus nerve is very important. Also, your cranial nerve 9, glossopharyngeal nerve, also plays a role in transmitting that information. What else? So over here, you can see some of you have some of these baroreceptors or stretch receptors that are found. There's also chemoreceptors that'll be found over here within the aortic bodies. And again, they're constantly detecting change. Higher levels of oxygen or lower levels of oxygen, carbon dioxide or hydrogen, it's going to send a signal to the pons, and then you end up, your breathing rate gets altered. Too much carbon dioxide, now the dorsal respiratory group is going to get activated from the pons. Why? To remove that excess carbon dioxide and decrease the hydrogen ion, also hydrogen ion level. All right, so that's it for chapter 23. All right.